Welcome to the deep dive. Today, we're venturing into a really fundamental process our bodies perform constantly, usually without us even noticing how we stop bleeding.
hmm
Specifically, we're going to unpack coagulation factor deficiency. What happens when that system, the one designed to plug leaks, doesn't quite work right?
Right. Think of our blood vessels like this incredibly complex network of pipes. And when one gets damaged, these coagulation factors, they're procoagulants.
Meaning they promote clotting?
Exactly. They promote clotting. They're like the specialized repair crew that rushes in to form a patch. Today, we're looking at what happens when, the crew is short-staffed or maybe their tools aren't working.
Okay, got it. So this deep dive, we'll explore the definition, the underlying mechanisms, sort of the nuts and bolts, and the potential consequences if these critical proteins are missing or just malfunctioning.
Yeah, and our sources today give a really detailed picture of all that.
And what's interesting, you pointed this out earlier, is it's not always genetic, is it?
No, not at all. That's fascinating right off the bat. We see two main types: acquired deficiencies, which develop later in life because of other health issues, and then the hereditary ones.
Where it's in the genes from the start.
Precisely. It's like a problem with the factory itself versus, a flaw in the original blueprints.
Okay, let's unpack this then, starting right at the beginning.
Mm.
How does this whole blood clotting thing actually work? What's the role of these factors?
Well, it's a highly orchestrated cascade. Think of it like a chain reaction, maybe a biological Rube Goldberg machine,
Okay.
where one step triggers the next in a really precise sequence. The main goal, ultimately, is to generate this rapid burst of thrombin.
Thrombin, that's factor T, right?
That's the one. Factor T are right at the injury site.
Yeah.
This thrombin then acts on fibrinogen, another protein.
And chops it up.
Essentially, yeah. It chops it into fibrin monomers. These are the basic building blocks. These monomers then link up, get stabilized, and form a solid, insoluble fibrin clot.
The internal scab.
Exactly, a proper seal.
So if there's a deficiency in one of these factors, what part of that chain reaction goes wrong?
Well, if a key factor is missing, or maybe just its activity is way down, that critical burst of thrombin might not happen.
Ah,
Or the later steps, forming that stable fibrin mesh, they get disrupted. It's like having a missing gear in that machine you mentioned.
the whole thing just grinds to a halt.
Ugh.
Or maybe works poorly.
Precisely. Incompletely.
And our sources really highlight the liver's role in all this.
Oh, absolutely crucial. The liver is the main factory, the primary synthesis site for, well, the vast majority of these factors.
And there's something about vitamin K, too.
Yes, good point. Factors 2, 7, IX, and X, they have an extra requirement. They need vitamin K for activation after they're produced.
So even if the liver makes them without vitamin K.
They don't work properly. So a vitamin K shortage leads to functional deficiencies of those specific factors. It really shows how different body systems are all linked up.
Definitely. Okay, so a breakdown in this really finely tuned process that can lead to some serious problems, right?
Oh, indeed. The biggest risk, the most immediate one, is probably spontaneous hemorrhage.
Bleeding without an obvious injury.
Exactly. It can happen inside body cavities, like hemothorax bleeding into the chest,
Wow.
or hemoperitoneum in the abdomen. Hemarthrosis is bleeding into joints. Or you might see hematomas, those collections of blood under the skin or in muscle.
That internal bleeding sounds incredibly serious.
It absolutely is. And even with just minor injuries or, say, after surgery, people or animals with these deficiencies can bleed for way too long. It's hard to control.
And over time, that leads to.
Well, significant blood loss can eventually cause blood loss anemia, just not enough healthy red blood cells to carry oxygen around.
Okay, let's go back to those two main categories you mentioned, acquired versus hereditary. What's the core difference in where they come from?
Right, so acquired ones, like the name suggests, they develop during life. They're a consequence of some other underlying medical issue.
Okay, like what?
Several ways this can happen. Liver disease is a big one. If the factory, the liver, is damaged, it just can't produce enough factors. Simple as that.
Makes sense.
Then there's vitamin K deficiency. We touched on that. This can happen for various reasons. Eating certain rat poisons is a big one we see in pets.
Oh, the rodenticides that block vitamin K?
Exactly those.
Mhm.
But it can also be from problems absorbing nutrients or even sometimes long-term antibiotic use messing with gut bacteria that make some vitamin K.
Right. You mentioned other ways, too, for acquired deficiencies.
Yes, you could have factor inhibition. Something directly interferes with the factors working, like a heparin overdose maybe, or even certain snake venoms or insect bites.
Huh, okay.
Then there's factor consumption. The factors get used up way too fast, faster than the body can make more. This happens in a really serious condition called DIC, disseminated intravascular coagulation.
DIC, I've heard of that. Sounds bad.
It is very complex, very dangerous. Also, factor dilution. If you get massive blood transfusions or lots of plasma expanders, it can just dilute the factors already there.
Water them down, essentially.
Kind of, yeah. And lastly, there's hyperfibrinolysis. That's where the clots that do form get broken down way too quickly. So quite a range of things can knock this balance off.
That's a pretty long list for acquired causes. So what about hereditary? How do those come about?
Hereditary ones are down to genetics. Mutations, basically. Changes in the genes that are the instructions for building these factors.
They're born with it.
Born with predisposition, yes. Though the bleeding signs might not show up right away, severe defects, you often see signs pretty young, maybe 3 to 6 months old.
But milder ones?
Milder ones might only pop up after, say, surgery or some kind of trauma that really challenges the clotting system.
Gotcha. And the sources specifically mention hemophilia A and B. Can you tell us more about those?
Sure. Hemophilia A is a factor VIII deficiency. Hemophilia B is factor IX. They're sort of the classic examples.
And they're genetic?
Yes, they're X-linked recessive traits. The genes for factor VIII and IX are on the X chromosome.
So that affects males more?
Typically, yes. Males have one X and one Y. If they inherit that faulty X, there's no backup copy on the Y, so they usually show the bleeding tendency.
But females have 2 X chromosomes.
Right. So generally, a female would need the faulty gene on both X chromosomes to have severe signs. Or they can be carriers, have one faulty copy and one normal one, which often masks the defect.
And this happens in dogs and cats?
Oh, yes. Both hemophilia A and B occur in both species.
What about other hereditary types beyond hemophilia?
Most of the others follow an autosomal pattern. The gene is on a non-sex chromosome.
So males and females are affected equally?
Generally, yes, assuming they inherit the faulty genes. And while, certain breeds might have a higher prevalence of specific defects because of how genes get passed down.
Line breeding and such.
Right. But new mutations can technically pop up in any breed.
There was also that really interesting point about factor 12 deficiency in cats. It's common, but usually no bleeding. Why is that?
Yeah, that is fascinating. Factor 12 is part of the contact activation pathway, one of the early steps in the intrinsic pathway.
Okay.
But it seems that in cats, other pathways can compensate pretty well if factor 12 is missing. So even though lab tests pick it up, it often doesn't cause actual bleeding problems.
So the lab test looks abnormal, but the cat is fine.
Often, yes. It highlights that lab values don't always perfectly match the clinical picture. The body has backups, redundancy.
Right. So if an animal is showing abnormal bleeding, how do vets figure out if it's a coagulation factor deficiency? What's the diagnostic approach?
Well, the very first absolutely critical step is ruling out thrombocytopenia.
Low platelet count.
Exactly. Platelets are crucial for that initial plug, so low platelets can definitely cause bleeding too. If the platelet count is okay, then we start digging into factor problems.
And you look for those underlying causes for acquired issues.
Yeah, acquired coagulopathies often link back to other diseases. So we think about liver disease, possible rodenticide exposure, DIC, those are high on the list. We look for clues in other tests, like a CBC or blood chemistry panel, things that might point to liver trouble or other systemic issues.
And the specific coagulation tests give big clues too, right?
Huge clues. For instance, with those vitamin K blocking rodenticides, we typically see both the APTT and the PT tests prolonged.
Okay, APTT and PT. We'll get to what those mean in a sec.
Right. But with rodenticide, the TCT and fibrinogen levels are usually normal, at least early on. With DIC, you often see low platelets and prolonged clotting times.
Complicated picture.
Very. And remember, massive transfusions can dilute factors too. And hereditary deficiencies, they will generally prolong these screening tests. That helps distinguish them from something like von Willebrand disease, which usually doesn't affect these specific tests.
Okay, you've mentioned these tests, ACT, APTT, PTT, CT. Can we break those down? What are they actually measuring?
Sure. They're all functional tests. They measure how long it takes for a blood sample to clot under specific lab conditions.
Got it.
The ACT, activated clotting time, is a quick, often cage-side test. It detects severe deficiencies in most factors, but it's not super specific. It can be affected by anemia, low platelets, stuff like that.
Okay, what about APTT?
The activated partial thromboplastin time. That mainly checks the intrinsic pathway and the common pathway. So factors like 8, 9, X, F12,
MET.
prothrombin time. That looks mostly at the extrinsic pathway and the common pathway. It's especially sensitive to factor 7 activity.
TC.
Thrombin clotting time. That one specifically looks at functional fibrinogen. Can it polymerize? Can it form that clot? It's also sensitive to things that might inhibit fibrinogen.
So broadly speaking, what patterns might you see, like acquired versus hereditary?
Well, acquired problems often hit multiple factors because there's usually an underlying systemic issue, right? So you frequently see more than one of these tests prolonged, PT and APTT, for example.
Yeah.
Whereas for common hereditary ones, like hemophilia A
Yeah.
or B factor 8 or IX deficiency, that's mainly the intrinsic pathway. So you typically see a prolonged APTT, but the PT and TUCT would likely be normal.
And that factor 12 in cats would also just prolong APTT.
Primarily, yes. But for a really definitive diagnosis, especially if you suspect a hereditary issue or it's complex, you need individual factor assays.
Testing each factor specifically.
Exactly, measuring the concentration or activity level of each one.
Are there pitfalls with these tests? Things that can mess up the results?
Oh, absolutely. Sample collection is huge. A traumatic blood draw, not filling the tube right, using the wrong anticoagulant tube,
Yeah.
all can wreck the results.
Garbage in, garbage out.
Pretty much. Also, things in the blood itself, high fat levels like lipemia or bilirubin icterus, can interfere with the lab machines.
Okay.
And some factors aren't very stable, so ideally you test samples quickly or you process them properly, spin down, separate the plasma, freeze it if needed.
And using the right reference ranges.
Crucial. Absolutely crucial. What's normal for a dog is different for a cat, which is way different from a human. You have to use species-specific ranges.
Okay, so let's say we've navigated the diagnosis. We know there's a factor deficiency. What do we do? What are the treatments?
The main strategy, the cornerstone really, is replacement therapy. Transfusions. Giving back the factors that are missing or not working.
What kind of blood products?
Well, fresh whole blood, fresh plasma, and fresh frozen plasma FFP, they all contain all the coagulation factors.
So they cover all bases.
Generally, yes. Then there are more specific components. Cryoprecipitate, for instance, is concentrated in factor 8, fibrinogen, and von Willebrand factor.
Useful for hemophilia A then.
Exactly. And the leftover plasma, the cryosupernatant, has the other factors, like the vitamin K-dependent ones.
Is component therapy preferred sometimes?
Often, yes. Especially maybe before surgery or if the patient isn't anemic. Using just the needed component avoids giving extra red cells they don't need, reducing risks like sensitization or fluid overload.
And sometimes multiple transfusions are needed.
Oh yeah, for severe deficiencies or if there's ongoing bleeding, repeat transfusions might definitely be necessary to stop the hemorrhage.
What about for specific types, like the acquired ones, if it's vitamin K deficiency?
Well then the primary treatment is giving vitamin K1. That's vital for rodenticide poisoning cases.
Makes sense. Fix the underlying problem.
Exactly. And you also have to be careful what other medications you give. Avoid things that impair clotting further, like NSAIDs.
Right. Non-steroidal anti-inflammatories.
Yep. And other anticoagulants, obviously. Even plasma expanders can sometimes interfere. And you'd want to avoid procedures with higher bleeding risk, like injections into muscle or putting in jugular catheters if possible.
Are there other drugs? You mentioned antifibrinolytics.
Yes, those drugs help prevent clot breakdown. They can sometimes be used as an extra therapy, but honestly, their role and effectiveness in veterinary patients are still being studied quite a bit.
Okay. So once treatment starts, how do you know if it's working? How is it monitored?
Good question. For vitamin K deficiency, you can monitor the PT, or specifically factor 7 activity, since it has the shortest half-life.
So you expect those to get better.
Yeah, you should see those times start to normalize, usually within 24 to 48 hours after starting vitamin K1. The ACT can also give a general idea of improvement.
And for hereditary defects, where you're giving factors.
There, monitoring is often more clinical. Is the bleeding stopping? Is the red cell count, the hematocrit, stabilizing? Are any hematomas resolving?
So watching the patient closely.
Very closely. Sometimes, especially with hereditary cases, you might repeat specific factor assays to see what levels you've actually achieved to the transfusion. And you always have to watch for transfusion reactions too.
Right, potential complications, immune reactions, other things.
Exactly. Immune or non-immune issues like fluid overload or even transmitting infections. Though screening helps minimize that.
Okay, we have covered a lot of ground here. Let's try and synthesize this. What are the big take-home messages about these deficiencies?
I think the biggest thing is realizing just how intricate and finely balanced coagulation really is. These deficiencies just hammer home how vital these proteins are for keeping everything sealed up, for hemostasis.
And understanding them means looking at both genetics and external factors.
Absolutely. You have to consider the interplay between the intrinsic stuff, the genes, and all these external influences, disease, toxins, you name it.
And getting the diagnosis right is key.
Paramount. Using careful assessment, the right lab tests. That's what guides the best treatment and hopefully leads to better outcomes.
So, to quickly summarize our deep dive, coagulation factor deficiencies mess up the body's ability to form clots. They can come from lots of different causes, acquired or hereditary, and lead to some pretty serious, potentially life-threatening bleeding.
Right, that distinction between acquired problems picked up during life and hereditary problems present from birth due to genes is really fundamental.
Which leads us to a final thought for you, our listener.
Yeah, considering just how complex this whole coagulation system is, all the interconnected parts we've talked about, what other factors, maybe less obvious ones we didn't even touch on today, might also influence how well our bodies stop bleeding?
Something beyond the basics we covered.
Exactly. It's a system with so many layers. There's always more to explore, more potential influences than just the core factors we focused on. Something to think about.